going to discuss with you today is when to use insulin, because insulin obviously, start why insulin, because it's very effective in lowering the plasma glucose concentration. And it's natural compound, and therefore it has no adverse events. And there's no limit on the dose. We can give as much insulin as we want unless there's a hypoglycemia. So, but nonetheless, there are many limitations for the use of insulin. The most common one, as everybody knows, is increased risk of hypoglycemia, because if we give too much, we can lower the blood sugar below the normal level, and it's also associated with weight gain. And here are just a graph to remind you from the DCCT is that the lower the A1C, as we get closer to the range where we want patients to be, we increase the risk of hypoglycemia. And actually, indeed, that's one of the major factors that causes fear among the doctors as well as the patients in pushing further the insulin dose in order not to run into hypoglycemia. The other major problem with insulin is it's a symptomatic treatment. It doesn't correct or improve or treat the underlying cause that caused the hyperglycemia. It's just you are giving Tylenol to somebody who comes to your office with a fever. And therefore, the underlying cause the underlying disease continue to progress, which is the beta cell failure. And as a result of that, when you give insulin, you don't produce durable reduction in the A1C. And this is nicely demonstrated both in the UKPDS in people with newly diagnosed type 2 diabetes, as well as in the recently published GRADE study, in which they took people who failed on metformin and then they gave him glargine again. They thought the UKPDS might be wrong. Therefore, in metformin failing, and over 5 years, you see exactly the same replica of the results of the UKPDS. So you are here treating symptomatically people with diabetes. You are not treating the disease, you're treating the symptom. And lastly, because insulin has no benefit in terms of reducing the risk of complications beyond lowering the blood sugar. So it has no cardiovascular, no direct renal effect. Those benefits that we know now recently we have from many other classes of glucose-lowering drugs. And this is an example for the Origin study in which they looked into glargine for people with newly diagnosed diabetes to see the effect on cardiovascular outcome. And as you can see, you cannot get a better superimposed curves than those showing that glargine has no benefit in terms of cardiovascular outcome. So therefore, then, why to use insulin comes the question. And the patient who needs insulin is the patient, the only patient who needs insulin is the patient who should be given insulin. And for all of the old conceptions, early insulinization and intensification of insulin and all kinds of that stuff of insulin, that's basically misuse, I would describe it, of insulin. And only people who need insulin should be given insulin. And the question then becomes, which type 2 diabetic patient needs insulin? Obviously, all my discussion here is about type 2 diabetes, because type 1 diabetes is a completely different disease. Those patients always need insulin. And in order to understand who needs insulin, we have to go back to understand for the pathophysiology of diabetes. And this is one of the first studies done by Dr. DeFronzo. I think it's still the best study that shows us the natural history of diabetes. And I'm going to go with you quickly over this. I'm sure you have seen that many times. This is a large patient population in which each one of them received either insulin clamp to measure insulin sensitivity with the gold standard. And you can see in the upper panel in the right. And then they received OGTT to measure his blood sugar and the lower panel, and to measure in the left there how much the pancreas is making insulin during the OGTT. And as you can see in the first dot in the left, and each one of those dots is the average of 250 subjects, means this is a large patient population. People who have normal glucose tolerance, lean, during their oral glucose tolerance, their mean plasma glucose is around 100. That's the best you can get. In order to achieve that, your insulin sensitivity, if you look up, it's around 300. Doesn't matter what the number is, but you are highly insulin sensitive. And for that insulin sensitivity, your pancreas is making about 60 units of insulin to to maintain that good glucose. Now, what happens if this normal individual gains weight? This normal individual, once he gains weight, the first thing that happens, you can see that his insulin sensitivity dropped markedly. So instead of having 300, he's almost now 200 or less than 200. Now, despite that large drop in insulin sensitivity, does that patient becomes hyperglycemic? If we look at the glucose, his glucose is still the same. So meaning, even though one gains weight and becomes hyperglycemic, that's not necessarily is going to develop diabetes or become hyperglycemic. And the reason is because if we look at the middle panel, we see that the pancreas now is making much more insulin. So the pancreas will read how much the insulin sensitivity is and will compensate by increasing the amount of insulin that is secreted to overcome the insulin sensitivity, the insulin resistance. Now, if that obese people, obese subject progress to become pre-diabetes, so the glucose will increase a little bit. But what happens is that there's a marked drop, further drop in the insulin sensitivity, and you can see now the body now is metabolizing about 100 milligrams of glucose. So there's a major drop in insulin sensitivity from 300 to 100, and very little change in glucose. That's because the pancreas, again, can further increase amount of insulin that is secreted. But when that patient with pre-diabetes now suddenly becomes diabetic, is it because he's more insulin resistant? If you look at the insulin sensitivity, it's still the same. He still has 100. But why that his sugar jumped from around 200 to 300, 250? It's because the pancreas no more can cope with this demand of insulin and therefore failed to secrete insulin, and that's what makes patients hyperglycemic. And as diabetes progress, you can see that there's further decline in the amount of insulin made by the pancreas, and therefore the hyperglycemia becomes worse and worse. So what causes the hyperglycemia to develop and to progress in people with diabetes is the lack of insulin from the pancreas. So who needs insulin? Only patients who don't have insulin in the pancreas. If your pancreas is still capable of secreting insulin, then we can use that endogenous insulin without the need of giving you exogenously insulin. And this is data from the UKPDs in which show that the progression, continuous progression of the A1C over time, that's because of the continuous decline of beta cell function. They have HOMA beta here. It's some sort of measure for the beta cell, but that's the continuous decline of the beta cell of insulin secretion. That's what makes the A1C continue to progress. So therefore, the question is, at what level of beta cell function we need to start insulin, and at what level we still can manage the patient without an insulin? Now, if you look at the guidelines, they would tell you all patients with long-standing diabetes with multiple oral agents just start insulin, 2 or 3 oral agents. Now, to address this question, here again, the Qatar study that Dr. Malik mentioned, and in which we took people who have long-standing diabetes on metformin and sulfonylurea maximal dose, and they are poorly controlled. So the guidelines will tell us, some of them also were on DPP-4 inhibitors. So the guidelines tells us that those people should be given basal bolus insulin. So are all of them need basal bolus insulin? We don't think so. We think a better therapy is to give them exenatide plus pioglitazone in order to make use of their endogenous insulin. And therefore, that's what we compared, see how much we can maintain their A1C less than 7. These are the baseline characteristics. And as you can see, the people have diabetes on mean about 11 years. Their mean A1C, starting A1C, remember, was 10. We have no limit on what upper limit of A1C should be to be included in the study. And all patients were in maximal dose in metformin or sulfonylurea. So half of them received basal bolus insulin, glargine plus novorapid, and the other half received pioglitazone with weekly exenatide, GLP-1 receptor agonist, because that's the only long-acting GLP-1 available at the time. And as you can see here, the A1C dropped very rapidly in both arms, both with who received insulin and both who didn't receive insulin. But in those who received the combination therapy of pioglitazone plus GLP-1 receptor agonist, there was a much greater reduction in the A1C, and the reduction in the A1C was to lower level, And I'm not showing it here, and lasted for a longer period of time, 3 years, which is the duration of the study. But even though the mean A1C was lower in people receiving combination therapy, not everybody responded similarly. This is the mean A1C. So if we take what percentage of people achieve the A1C less than 7, we see that 83% of people receiving the combination therapy achieved A1C less than 7, even though they had 10 years of diabetes on mean. Their mean A1C, starting A1C was 10, and they were on maximal multiple oral doses. That's exactly the same patients that the ADA tells you they should be put in insulin. Nonetheless, 83% were perfectly managed without the need of insulin. But still, that means there are 17% who were not achieving the goal despite giving this combination therapy. Now, to show you a remarkable thing is, we took those who received the combination therapy. As I told you, there was a wide range of A1C from 7 up to 14. And then we asked the question whether those who didn't respond because they had the higher A1C and therefore they didn't reach the target for A1C less than 7. So what we did, we divided the patients here in this slide, whether the starting A1C was 10, less than 10, so their mean A1C was about 9, or they started with A1C above 10, and their mean A1C was almost 12. And look what happened. When you give the GLP-1 plus TZD, regardless where you're starting A1C, you always go down almost to the same level. Meaning, if you correct the underlying cause, if you treat diabetes, you fix the problem, the symptom, the hyperglycemia goes away. We're still left with those 17% who did not respond. We'll come to them later. So let's see who are those 17% of patients who did not respond to this therapy and therefore required insulin. So this is the oral glucose tolerance test before and after. And as you can see, those who didn't respond with the open label, they have a little bit higher glucose, but not that much. And the glucose excursion looks the same whether you responded or didn't respond. But what was the major difference? The major difference in how much the pancreas made insulin in those who did respond versus those who didn't respond. You can see here in the left is the insulin, and in the right is the C-peptide. And as you can see, that during the OGTT, people who responded, 87%, they have very high curve, very much, the pancreas made a lot of insulin during the OGTT. And those who did not respond, those 17%, they had much lower, much more flat curve, or their pancreas did not respond to insulin. So in other words, if your pancreas still have some functionality in terms of secreting insulin in response to glucose, you don't need to give him insulin. You can fix the glucose control very easily with a combination of GLP-1 and TZD that fix the underlying cause, and you can achieve the A1C in a very low level. Only those who have their pancreas run out of insulin, is not producing enough insulin, those are the ones who need insulin to be replaced. And the question now is for you or for me as a clinician, when tomorrow morning the next patient comes to see me who has long-standing diabetes, who is on multiple oral agents, how to decide which patient his pancreas run out of insulin or belong to the lower curve that I will give him insulin, or that patient belongs to the upper curve, doesn't need insulin, I can fix his glucose without the need of insulin. So the predictors for those who failed to achieve, failed to be controlled without insulin, BMI was predictor, significant diabetes duration, and Matsuda index of insulin sensitivity, although statistically significant, but I what would call it statistical significance, but clinically irrelevant, because the magnitude, the size of the effect was 10%, 15%, the best 20%. But look at the bottom line. The increase in C-peptide over the baseline during the OGTT predicted in 33-fold, means 3,300 times who is going to need insulin and who is not going to need insulin. And if we process that statistically, we take the increment, the increase in the area under the C-peptide curve over the fasting C-peptide, if that ratio is above 1.6 on 80% sensitivity and specificity, you can detect who is not going to need insulin. Or if that ratio is less than 1.6, that is the patient that you need to include insulin in his treatment regimen. So now, which patient then who needs insulin? Patients who has the delta C-peptide, the increase in C-peptide above baseline, less than 60%, that patient is the one who needs insulin. Otherwise, you don't need insulin and you can manage him without insulin. Okay, what about newly diagnosed people with diabetes? So this is with long-standing diabetes. For that, we had the EDICT study in which we have exactly the same the same arms. One arm received combination of GLP-1 receptor agonist plus TZD and metformin, and the other arm is on patient receiving, starting with sulfonylurea, adding metformin, and then insulin, exactly as the ADA was recommending a few years ago. And the only difference from the Qatar study is that those patients were drug naive and newly diagnosed type 2 diabetes, newly diagnosed type 2 diabetes. And the aim here, because they were newly diagnosed, was to maintain them with A1C less than 6.5. And exactly very similar results you can see. Those who received the triple therapy were much better controlled, and their control continued for a longer period of time compared to those who didn't receive the triple therapy, who received sulfonylurea, metformin, and insulin. And the same thing, there was achieving the goal was much higher with the triple therapy. But nonetheless, there's a few percentage of those newly diagnosed people with diabetes who still couldn't reach the goal of A1C less than 6.5 in this case, even though we hit them with the triple therapy. And if we look into who are those who needed insulin versus those who didn't need insulin, we see exactly the same thing. Those who were well controlled on metformin or metformin with SE, their pancreas did much better in terms of secreting insulin than those who required insulin. And here, remember, this OGTT was done at the time of diagnosis. These are newly diagnosed. So even if you have now not only long-standing diabetes, even if you have a patient with newly diagnosed, and you do this test, and you don't see the pancreas is secreting insulin, don't waste your time on metformin. You know that this patient is going to need insulin, and therefore it's better now to start insulin as early as possible. Now again, if we look at the left column, you see there was no difference in insulin sensitivity whether people needed insulin or people didn't need insulin. What was the difference is in the right panel, you see those who required insulin, their pancreas made much less of an insulin. And when we dichotomize the same thing as we did before, so interestingly, even in people with newly diagnosed, people who required insulin who had this ratio less than 1.8. Remember there with people with long-standing diabetes who had less than 1.6. So meaning if you have an increase above baseline in terms of insulin secretion, less than 60 to 80%, your patient is going to require insulin no matter what treatment he received and no matter how long diabetes he has. Those are the subgroup of patients who really require insulin. Even we'll go farther. I told you in the two studies, we have no upper limit in including people into the study. All the drug companies that they showed you about, all the therapeutic studies that they show you, they deceive. Why they deceive? Because they pick up a patient between A1C 7 to 9, between 7.5 to 10. So they have very narrow range of A1C. And that's, of course, make it unapplicable for if patient comes with A1C of 12, because it wasn't included. In this study, we want both studies to be applicable to the as wide population as possible, and therefore we didn't limit what A1C to start. So as I showed you in the Qatar study, many people started with A1C above 10. So the guidelines, if you look at the guidelines, and that's how I see in the practice, anyone who comes, whether newly diagnosed or long-standing with A1C above 10, everybody gives insulin. And I'm sure many people here do. The question is how those who started with A1C above 10 did compare to the others. And as you can see here, regardless where your A1C is, ones who received the triple therapy, they did exactly the same as those who received the conventional therapy in terms of lowering the A1C. And again, when we looked at those who started with A1C above 10, who required insulin, regardless on both arms, their insulin sensitivity was different, was similar. But what they differ in is how much the insulin secretion, which you see in the right panel, the light blue, you can see whether they're on the conventional therapy or in the triple therapy. Those who started with lower amount of insulin secretion, those are the ones who required insulin. So basically what determines whether you need insulin or not is how much your pancreas is making insulin. And surprisingly, when we did this dichotomy again, even if you started with A1C above 10, if your ratio was above 1.7, you didn't need insulin. So it seems that if your pancreas is capable, after you give a glucose load or glucose challenge to the pancreas, if the increase in insulin secretion 2 hours after that challenge is more than 70% or 80%, I take it in practice as a rule of thumb as twofold increase. Above baseline, regardless where the baseline is, that patient doesn't need insulin, and you can manage him on a different therapy, oral therapy, whether he is newly diagnosed, whether he is on drug naive or on other oral agents, regardless what the A1C is, below 10 or above 10. So then to summarize, insulin is very effective in lowering the plasma glucose concentration, but it has a lot of limitations that I went through over. And which patient who needs insulin? The patient who needs insulin, the one who doesn't have endogenous insulin secretion. And here you have a tool, a practical tool, that you can use it to identify those patients who don't have insulin by giving him glucose challenge. I just ask the patient to bring a drink, a bottle of drink with a sandwich, to take C-peptide at the fasting 2 hours after he eats the meal. And then if the ratio increases more than twofold, I guarantee the patient that I can manage his glucose regardless where he is, what his condition are, with the oral agents. I even have patients who are coming on multiple daily injections, 4 injections of insulin, high doses of insulin. And when I see him clinically, that probably he's going to have, this patient has endogenous insulin secretion, and I do this test and I get this result, I get them off insulin with improved in the A1C. So to summarize, which patient needs insulin in type 2 diabetes? Only patients who don't have endogenous insulin secretion, and this ratio of increase in C-peptide upon a glucose challenge 2 hours after, if it's above twofold of the fasting, for example, if the fasting is 1 nanogram per ml, if it's above 2 after he eats the meal, that patient, you can assure him you don't need insulin. Only for those who have lower challenge, lower C-peptide in the challenge, those who need insulin. And again, if that patient is newly diagnosed, don't waste your time on metformin. Give him metformin, but don't forget to give him the insulin as well. Thank you very much for your attention.
Thank you, Dr. Mohammed Al-Ghani. Next lecture for Dr. Ralph DeFronzo. Professor Ralph DeFronzo finishes baccalaureate from Yale University. His medical, he finished his baccalaureate in medicine in Harvard School.